For our skills lab content, one of the first procedures we want to talk about is trach care on a patient. So first and foremost, what is a tracheostomy? So what it is an artificial opening into the upper airway, meaning into the trachea. So we're bypassing the oro and nasopharynx and accessing the trachea directly through the neck, which you can see here. But it is just an artificial airway that accesses the trachea at the level of the neck rather than using the natural airway, which is the mouth and nose. Here's what some of the equipment can look like when it's all in place on a patient, but you will always see this little plastic piece coming out of a patient's neck with a strap going around to secure it in place. What it's hooked up to will depend on the patient's condition, and we'll talk about that in just a bit. So first thing I want to talk about is the difference between a tracheostomy and a tracheotomy. So the tracheotomy is cutting the part of the body, so that's the surgical procedure. When a patient has a tracheotomy, that's them having surgery to have a trach placed in their neck. Tracheostomy is the surgically created opening. So when patients have the opening in their neck, when they have a trach in place, the equipment in place, they have a tracheotomy. A lot of times you will hear these terms used interchangeably when you're in a care environment, but that's really what they mean. The tracheostomy is what we're really dealing with. The opening is what we call a stoma. And stoma is just, we're used to thinking of a stoma as like a bowel diversion type of thing, but a stoma is just an opening. It's just a hole. So your mouth is technically a stoma, it's just an opening. So that's all that means. So why we do this, we're bypassing the upper airway, the oro and nasopharynx, in order to facilitate the removal of secretions, and because something is going on in the upper part of the upper airway, in the oro or nasopharynx, that makes it unsafe to rely on that kind of plumbing for ventilation. So we have to go down to the next safest place, which is in the neck. One of the big risks here is mucus production and clearing mucus, because we are limiting the size of the airway by our hard plastic tube that we're inserting. So it's a static size, whereas the trachea is larger and able to clear mucus more effectively. So mucus plugs are a complication that we want to look out for, which is just like a big nasty loogie booger that blocks this smaller tube that we're inserting into the trachea. The other reason that we may do these is for long-term mechanical ventilation. So patients that are going to be on vents long-term, like in an LTAC or a long-term acute care facility, is another reason that we do this. Some of the other reasons why we do this or the reasons why we replace these tubes, because a lot of times they can be inserted kind of urgently as patients are not able to protect their upper airway, or they lose patency of their upper airway, kind of in the oronasopharynx area, is to decrease the risk of long-term airway damage. So we don't want any long-term trauma to impact their ability to breathe naturally long-term. Improved comfort and mobility. So for patients who have, especially like head and neck, head and cervical spine trauma, this can actually improve comfort for them versus being intubated through their mouth, and the ability to eat, drink, and speak. When we intubate patients through their mouth, they lose those abilities because the tube that we're putting in is impairing their ability to eat, drink, because we blocked their mouth, and speak because that's where the tube is going. We're diverting everything that goes through their mouth into their lungs if we intubate traditionally. With a trach, we're only accessing the airway. So these patients are able to use their mouth and their esophagus like they normally would. So complications of trach fall into two different categories. There's the short-term complications and the long-term complications. Our short-term complications really kind of orbit around all the risks and problems associated with the actual surgery to make the opening and place that trach. So things like bleeding and a pneumothorax. So damaging things accidentally with the cutting necessary to place this. Subcutaneous mediastinal emphysema. So when we cut anything associated with the airway, there's a risk that air can end up in the subcutaneous tissue, which is what that's talking about. Nerve damage, particularly laryngeal nerve damage, because we are dealing with the airway. And posterior wall puncture, going too deep and completely going through the trachea. So these are all surgical complications that patients may be exposed to. Long term, we're looking at much more like respiratory complications associated with having an open airway to the environment all the time. So things like obstruction, we talk about mucus plugs, because patients don't have their natural airway the full diameter. There is a risk of obstruction from those mucus plugs. And we call it a plug just because it completely occludes. Patients naturally produce respiratory mucus just like all of us do, and they're usually able to clear it. The mucus plug is kind of the most extreme version of that. Infection, because we have created a portal of entry into the respiratory system. We've bypassed a lot of the natural ways people combat infections. Rupture of the carina. So here's one of the messed up things about trachs, is they go down right in here, and the bottom end of the trach sits right here by all of these arteries and veins. One of the big risks for patients that have trachs long term is that hard plastic can put pressure on their trachea and actually cause a pressure injury internally, which can rupture into those vessels, causing massive bleeding into their trach. But this happens after like decades of trach use and continual pressure. Modern trachs have a lot of equipment that prevents this kind of pressure injury from happening internally, so we do try to minimize that risk. Dysphagia, difficulty swallowing, fistula formation, so an artificial kind of path between two different places, which would be like that carina rupture would be a fistula formation. Tracheal dilation, if we put too much internal pressure on the trachea, we can dilate it and cause it to kind of malform. And tracheal ischemia, necrosis, so this is talking about like the pressure injuries that we can cause from internal pressure on the tracheal tissues. Another key thing we need to talk about when we're assessing and suctioning is patients have to be on heated and humidified oxygen when they're breathing through their trach, especially with new trachs. The reason for that is usually the mouth heats and humidifies air before it passes into the trachea, into the lungs. Because those are wet mucous membrane surfaces from our surfactant, we do want to make sure that we're not causing irritation to that tissue lining by breathing in just raw atmospheric cold air. So that is one of the things that we want to look out for. Oh, also real quick, there are links to videos throughout this presentation. You can access those directly through the PowerPoint. I will try to put all the links to the other videos down in the descriptions for this video as well. Where is it done? So below the larynx, between the first, second, or third tracheal cartilage rings. So not kind of the big one up top. When you start getting into the individual little rings that are about the width of your little finger, that's kind of where we're going to be doing that. And by we, I mean not nurses, but surgeons are going to be doing this procedure. This is kind of the general area where they're looking to make that incision and where that trach's going to be living for that patient. Here's all the equipment. So first piece of equipment that you're going to see when you're taking care of a trach patient is what's called the outer cannula. It's the part you can see on the patient's neck for a patient who has a trach. It has the collar, which is this kind of plastic flange piece that'll rest against the skin, and then the cuff, which is an internal balloon that helps to stabilize it. I'll show you a better picture of the cuff when it's inflated, but this balloon piece coming out of the trach, you can see it coming out right here, kind of tubing going around. What this will do is if we've inflated the cuff, the air pressure in there will also inflate this balloon. So you can kind of squeeze the balloon a little bit, and if you feel air pressure, that means the cuff is inflated. These cuffs should not be inflated more than 20 millimeters of pressure, and they use a little manometer which is just like a little pressure gauge on a syringe that they hook up to that to make sure it doesn't go above 20 millimeters. And by they, I mean usually respiratory therapy helps us with that. The next few pieces we want to look at are the inner cannula. So this is another tube that goes inside the outer cannula. It's almost like a liner on the inside of that trach. And when we do trach cleaning, what we're doing is we're taking this inner cannula out, sanitizing it, and replacing it. That's what trach care is the cleaning of that inner cannula and of the insertion site where the outer cannula is kind of resting against the skin or going into the patient's body. And then we have our obturator. It's this piece right here. The obturator is only used for insertion of the outer cannula. So it's used with initial placement of the trach by the surgeon. It's also used in an emergency in case the patient accidentally removes their outer cannula and we have to replace it emergently. We can put that obturator in so that there's not a sharp end that we're puncturing into the patient's skin. This makes it a blunt end to minimize our risk of puncturing all the way through the trachea should we have to emergently reinsert or reposition this thing. Few different types of trachs that patients have. So they come in different types of devices. First one we want to look at is called a fenestrated trach. So this allows air to pass over the vocal cords so patients can speak with this type of trach. So when they breathe in, air goes in through the trach, but it's got this little hole right at the top where it curves out of the body. It's called the fenestration. Because this hole is there, when the patient exhales, air will go both out the trach and out their trachea, meaning that air will pass over the vocal cords. So these are patients who can speak with their trach. Some people just call it a speaking trach. Oftentimes this will be patients who have a very hoarse sounding voice. It's not very strong, almost like they're forcefully whispering. That's a common kind of how patients' vocal cords will sound with a fenestrated trach. Another type is called a speaking trach. We don't see these very much anymore, but this was kind of the original version of a fenestrated trach. What this is for patients who don't have very good kind of ventilatory capacity, meaning they're not able to ventilate very much tidal volume with respirations. There's going to be both a cuff, which you can see right here, this little balloon that kind of seals the trach in the trachea. And then there's this other little device coming off where they hook them up to compressed air. So when you guys are in hospitals or in care environments, you see the two little things on the wall. The green one is oxygen, like wall oxygen, and the yellow one just says air. That's what this is for. You can hook them up to just compressed air. And what that'll do is it'll blow air out the fenestration up their trachea over the vocal cords. So when the patient ventilates, when they breathe, all the air they breathe in and out of the trach just goes down into their lungs. But the compressed air goes up over their vocal cords so the patient can speak. By far the most common device that we use to allow patients to speak when they have a trach is a passe-mur valve. So this is like a one-way valve that goes like a cap almost, that goes over the patient's trach. We just physically put it on the end of their trach. And what it does is when they breathe in, they can breathe in their trach, but when they exhale, that valve closes, forcing the air to go up, and they exhale out of their mouth, like natural ventilation for exhalation. These trachs do not have a cuff like this. If we're using a cuff, we cannot use a passe-mur valve because what will happen is the patient can't exhale. So that's a very critical thing. Usually patients who are using a passe-mur valve long term will not have a cuffed trach in place. So they won't have this little balloon attached to their trach. So there's nothing to inflate. It's just the trach device, that little plastic curved piece going into their trachea, and that's what they're using for inspiration or inhalation. The big procedure we do with these things is suctioning their trach. So we do a lot of kind of suctioning to try and keep the airway open and kind of eliminate that natural mucus production that the body does. For adults, we want to aim for turning this little dial to the 100 to 120, so somewhere in the medium suction. For children and infants, obviously we're going lower. So for children, we're at the bottom end, kind of right at the low to medium border. And for infants, we are solidly dead smack in the middle of our low suction kind of range. Safety precautions, so this requires continual assessment when you're doing this procedure. Because when you're suctioning a patient's trach and suctioning their respiratory system, they can't effectively ventilate. So we need to observe for agitation, and this is like severe agitation. It's a little bit kind of agitating to do this procedure in the best of the cases, but we want to make sure the patient isn't in like obvious distress when we're doing this procedure to them. Color, we don't want them turning blue. Oxygen set, they need to have continuous pulse ox on while we do this procedure. And we want to actually hyperventilate them and hyperoxygenate them before we suction, anticipating that there's going to be a slight drop because it's almost like they have to hold their breath when we're doing the suctioning. So we do want to hyperoxygenate them ahead of time, and we want to listen to breath sounds. The whole reason we do this is to get rid of some of that rhonchi or mucus sound in the lungs. So we always want to assess before and after we do suctioning, just to make sure that we've actually done the job we anticipated. We don't want to suction for more than 10 seconds, because think of all the time you're suctioning, your patient's holding their breath. So we don't want to force patients to hold their breath longer than 10 seconds. It starts to get pretty uncomfortable pretty quickly for patients. If we need to do multiple passes, meaning we insert the suctioning device, take it out, and reinsert, that reinsertion is another pass in suctioning, we always want to give patients about 30 seconds to a minute to recover from the previous suctioning attempt. So always give them lots of time to recover their respiratory system between kind of that invasive procedure again. We can lubricate the tip with normal saline if needed. Usually, super important to keep in mind that when we're doing trach suctioning, this is a sterile procedure. So we are going to be sterilely gloving in order to provide patient with this treatment. We don't want to introduce or like inoculate their lungs with any environmental pathogens, bacteria, that sort of thing, causing pneumonia. So we never want to do this as a clean procedure. Always sterile glove. If you contaminate your sterile gloves, no big deal, just put on a new set. Cool? And then the catheters themselves, we really only consider them usable for 3 passes. Anything more than that, and we want to get a new sterile catheter and really reassess that patient's lungs, because clearly we're not being very successful in our attempts to suction that patient. Naso-Pharyngeal suctioning follows a lot of the same rules, but we're just looking to suck out the kind of nasal cavity of a patient. So we're still going to do this sterilely. We're going to use the same level of suctioning. We can use lubricant, but usually it's not necessary because the nose is kind of full of boogers and snot, so there's usually enough lubrication in there. It's not super awesome for patients, but usually they tolerate it kind of fair. But because we're sticking a tube like in somebody's body, we don't want to go rogue and just start doing this with the door closed, not telling anybody about it. So we want to get a physician order, just kind of an okay that yes, it's appropriate for you to be nasopharyngeal suctioning this patient. Here's what it looks like. It's all the same equipment that we would use for trach suctioning. We're just going through the nose instead of through the trach. All the same rules apply. Hyperoxygenate your patient. Don't suction for longer than 10 to 15 seconds. And always keep an eye on your patient, make sure they're tolerating it well. This is an oral suctioning. So oral suctioning, we're using what's called a Yankauer suctioning device, which is kind of like this little Harry Potter wand kind of thing that's hooked up to suctioning. And we're sticking it in their mouth to suck out kind of oral mucus and saliva. This is what gets done to you guys when you go to the dentist. So we're really not looking to suction past the back molars. So no like jamming it in there, inducing a gag reflex, no like whacking around their uvula, hanging down in their mouth. Just kind of right at the back of the kind of gums, at the back molars to kind of suck out anything in their mouth. That's the goal here. So for trach care, in general, these are the steps. The whole procedure is a little bit more complicated, and there's a video link here and on your trach care worksheet that you guys can refer to. But generally, step one, assemble the equipment and then explain the procedure to the patient, let them know exactly what we're going to be doing. Most patients that have a trach, they know what suctioning is about. Usually we're not, well, it's very rare that we're doing this for the first time on a patient. Any patient who's had a trach has had trach suctioning done, and they're pretty comfortable and familiar with it. Then we're going to suction our patient. So clean it out, do as many passes as you need, but every 3 passes you change out your equipment. Then if we're doing trach care to fully clean everything here, after we've suctioned and removed kind of the dirty phlegm, then we're going to remove their inner cannula and clean it with just kind of sterile water, sterile saline, or any kind of cleaning solution that comes in a kit. It's usually like a trach care kit. But we want to get all the mucus and kind of dried, snotty stuff off of there before we put it in there. Then we want to clean, so while sometimes you have to soak this to make sure you really get it all off of there, kind of like doing the dishes. While that's happening, then we want to clean and examine the stoma site. So this means all of the kind of plastic flange against the patient's skin, under that to where the insertion site for the trach is. Then we want to change the ties, which is kind of the necklace that holds it all in place. Then we either replace the inner cannula. If you're in a hospital, usually we just like toss the old cannula, put a new one in. If you're in a patient's home environment or long-term care environment, you're going to clean it and then replace it once it's clean. And then you're going to reassess your patient, right? We just did a procedure on their airway. We want to make sure we haven't introduced any fluid into their lungs or made it worse by doing this procedure. So you always, always, always want to reassess their respiratory system after you do a big intervention on it. And the same with any body system. After you do a big intervention on a patient, reassess that body system, see if it's different than it was before you did that procedure. But in general, those are kind of the broad strokes of what we're looking at when we do trach care on a patient. So this is suctioning and full cleaning of all the equipment associated with that tracheostomy. So nursing diagnoses that we want to pay attention to for patients with trachs. One is altered communication, because they are going to either have they're not going to be able to project their voice like normal because they have an artificial airway. So we do want to make sure that we're kind of paying close attention to what they're saying, even though it may be very difficult to hear them. Anxiety, because it's really weird when patients start messing with your airway. Not when patients start messing with your airway, but when you start messing with patients' airway. Knowledge deficit about the procedure, the experience of it. We want to let them know exactly what's going on, that they need to hyperoxygenate, so take some deep breaths with the oxygen on is common coaching that I give patients before I do suctioning on them. And then ineffective airway clearance. This is really the reason we're doing it, because they're not able to clear their airway themselves, so we need to suction it out. And then risk for infection. Anytime you're sticking a foreign body in a patient, risk for infection, always one of your big concerns. So removal. We want to start considering removal. That kid's crushing it. He got his trach out. Right on. So we want to consider removal or de-cannulation of a trach as soon as possible, because we don't want to keep indwelling devices in patients any longer than is necessary. The criteria we're looking for is a patient needs to be able to protect their natural airway, meaning they can exchange air and they can expectorate, meaning they can clear their own secretions. When they meet that criteria, Then we can talk about and start deciding when we're going to decannulate that patient or fully remove all that equipment and allow that stoma to heal naturally. It's closed with tape and covered with a dressing, usually like an occlusive dressing, and these things close crazy fast. I've had a patient that we decannulated and that thing closed within maybe 2 hours. The crazy thing was that patient had that trach for like a couple months. But that thing, it's kind of like an ear piercing. It's like you take that thing out of there and it just closes like that. So definitely make sure you mean to decannulate a patient when you do it. You can instruct the patient to splint the stoma with their fingers while it's still healing. So kind of like we do abdominal splinting when patients cough, hold a pillow against their abdomen. If they're gonna cough or do any deep breathing kind of stuff with that trach while it's healing, just put their hand over their neck to splint it and support it, mostly so they don't just like blow the dressing off across the room. But these things will close really, really quickly for patients. Documentation we're looking to do for patients when we're providing trach care. First, we do a respiratory assessment. So document your respiratory assessment. Then, if you've done suctioning, document what you did. How many passes did you do? What kind of junk did you get out of there? Was it clear secretions? Was it pussy secretions? That kind of stuff. And how did the patient tolerate it, right? Because we don't want to like cause distress to people. We want to make them better. So did you do that? Then what kind of equipment is in there? How the patient tolerated all the procedure. So a lot of this has to do if we're doing full trach care. And then patient education. Did you teach them anything? And when you think about patient education, it's simple stuff. Like take some deep breaths while you're on the oxygen before we suction you. That's patient education. It doesn't have to be like a lesson plan, all that kind of BS. It can be simple stuff. Most of the things that as nurses we tell patients about what we're doing is patient education. So feel free to take credit for that in your documentation. All right, that's it for trach care. Next, we're on to chest tubes.